Good morning, everyone. Welcome to day 2 of the Depression on College Campuses conference. I am Lindsay Mortensen, the Chief Mental Health Officer within Student Life and Executive Director of our newly merged unit on campus called University Health and Counseling, and it's my honor and pleasure to be here with you today. I hope you have found the sessions so far informative and insightful for those of you who participated yesterday. And I'm always impressed by the range of insights and work happening in the field of college mental health. So thank you all for your contributions and the really stimulating discussions yesterday. Our plenary panel today will be no exception, I think, to the thought-provoking groups that you attended yesterday. This past year, the University of Michigan University Health Service formed a committee to review serious adverse events through a peer review process within its Quality Improvement Committee. In healthcare, as you all know, adverse events are inevitable. Even when the best professional care exists and thoughtful systems are in place, adverse events can happen because of human factors, we're all human, and the complexity of the systems within which we work and provide care. In college health specifically, adverse events are often devastatingly students who die by suicide or who make suicide attempts that result in serious injury. As we all know, suicide is a complex phenomenon and one that often cannot be fully understood. And for that reason, our panel today is multidisciplinary and represents the fields of medicine, psychology, social work, law, and emergency services. This team on stage today is a critical part of our institutional efforts to continuously improve by looking closely at systems issues in an effort to thoughtfully appraise opportunities for improvement. Importantly, when organizations have a strong safety culture, professionals can speak openly and candidly about things that go wrong or could have gone better without fear of blame or punishment. This is the definition of just culture. That is, one that balances the need for an open and honest reporting environment with the end of a continuous learning environment that improves patient and client outcomes and experiences. I look forward to learning more from our panelists here today, and please join me in welcoming them to kick off day 2 of the Depression on College Campuses conference.
Hi everyone, good morning. My name's McGrady. I'm going to be kind of our moderator for this discussion, and we'll introduce ourselves in a moment. So I just wanted to do a standard disclosure slide that we have no financial interests or relationships to disclose for this presentation.
We also wanted to provide a content warning to the audience that we will be discussing things that could be upsetting or uncomfortable for folks. We also want you to know that while we will be presenting some cases, that it's not any particular case, it's just kind of an amalgam of experiences that we've had.
Yep, and I want to echo that and what Lindsay was talking about, that we're a group of clinicians. In medicine and in healthcare, there's been this idea of doing morbidity and mortality reviews, that when poor outcomes occur, we review these cases and we take this seriously and look into these things. But I think looking at our interdisciplinary group of attendees here, this may be new and a bit shocking for some people to see the way we're speaking with candor about these types of cases. So I just want to prepare you for that we're using different kind of standardized and systematic methods to make it more objective, but we recognize the gravity of these cases, and so we want to let you know that, give you that content warning. So I'm going to let each of our panelists introduce themselves and kind of tell us their role at the university. We have it in alphabetical order here.
Good morning, everyone. I'm Kelly Cruz. I'm an attorney for the university. I sit in the Office of the General Counsel, and I think I might be the only non-clinician up on this stage, so thank you for being here.
Good morning, everyone. My name is Jim Dolan, and I serve as the Associate Director for Clinical Services at Counseling and Psychological Services. I'm in my 9th year here at the university, and I'm happy to be here to talk with all of you.
Good morning. We only allowed one lawyer on the panel today. I'm Chris Frank. I'm the medical director at UHS. In my clinical world, I'm an addiction medicine physician and a primary care doctor, so I take care of lots of patients with co-occurring substance use disorders and mental health conditions.
Victor Hong, I'm a psychiatrist, medical director of our psychiatric emergency services here at University of Michigan, where a lot of the adverse events are connected with.
I'm Brianna LoPiccolo. I am a clinical social worker at University Health and Counseling.
I'm Angela McGrady. I am a family physician and I work at the University Health Service. I'm also the safety officer and the quality improvement committee chair at UHS, and so that will tie into kind of how we're doing this work. We do have some technology here today for trying to do a room poll, so I'm going to encourage everybody to take out their phones. For anybody who's interested in doing these sorts of presentations, this is from Slido. It's a free Chrome extension, and so it's going to live update for us the answer to this question, and then we also have a Q&A section in the QR code, so you can start writing in your questions as we're talking throughout the presentation, because the first half is going to be sort of us telling you the background of this adverse event committee, and then for us to all talk about it as a group. So we'll give a few moments here. I can see the numbers. We've got about 40 participants already. So I'm seeing about what I would expect here, that about a third of us are non-healthcare roles in faculty and staff at different institutes of higher education, and then a third of us may be clinical faculty or staff, and then a third of students or community members. I'm going to move on to the next question in our poll here. It should update right on that Slido website that you have open. You shouldn't have to do the QR code again if you already had it open. It should change questions. So we're just asking if you are a member of an institute of higher education, just for us to understand who all's in the room. I know I've met some people and looking through the program, but I wanted to see who's here today. And that's kind of about what I would expect, that about half of us are from U of M and half of us from other places. I thought maybe we'd have somebody from Canada, so I'm sorry I added that. And then our last sort of introductory slide here is just to tell you what we're going to talk about today. So we're going to talk about these serious adverse events and review what the common serious adverse events are on a college campus or in a college-age population. We're going to talk about the complex environment and stakeholders that are involved in college health critical incident response. And we're going to discuss our approach for serious adverse event review and kind of talk about how we came to that decision and utilizing our particular state's legal protections for healthcare quality improvement activities. And then we're going to have a good question and answer section. Everybody can hear okay? I'm seeing yeses. Thank you.
So I wanted to start out by just defining what we're talking about in terms of serious adverse events. We know that there are obviously lots of bad things that happen all over in all different kinds of ways, both on our campuses and off, and many of them are adverse events. Or we think of them as adverse events, and many of us think of lots of them as serious. But for this conversation and in healthcare settings, a serious adverse event is sort of defined as an event resulting in death or permanent harm. So these are not near misses or something we thought something was going to happen, or in this situation, it's not suicide attempt without permanent harm, but we're talking about really serious events that result in death or permanent disability. It could be either physical or mental. So when we think about what are the causes of serious adverse events in the age population that we're thinking of here, so adolescents and young adults, really the causes of death have not changed a lot. The number one cause of death in 17 to 24-year-olds is unintentional injuries, right? About half of these are sort of MVA, automobile type vehicular accidents. This category also includes unintentional overdoses, which is probably an increased topic on a lot of campuses because of penetration of our illicit drug supply with more potent opioids that cause a lot of deaths in the community. The second cause is suicide, and the third is homicide. And suicide and homicides are usually pretty close together. And then you see a big drop off, and we're into malignant neoplasms, so cancers, and then heart disease and a bunch of other smaller categories. When we think specifically about college students, we have a lot of interesting data that goes back quite a ways. So the first study looking at causes of death for college students really was published in the 30s, and it was essentially a 10-year snapshot of all 327 students who died on college campuses during that time period. And I just find it really interesting. So the first cause still was trauma, or we would call it unintentional accidents. And it was also divided into automobiles and other. The second category back then was, it says chiefly endocarditis. So some of you might be familiar with that. So that's an infection of heart valves. So this is heart disease that's caused by an infectious disease. And then the third cause then was suicide. And then if you kept going down the list, it's mostly infectious diseases, pneumonia, tuberculosis, septicemia, which is like a blood infection. And penicillin was invented in the 20s, but didn't really roll out until World War II. So this is all sort of pre-antibiotics and shows the really significant impact infectious disease had on student populations in that period. If we look at more up-to-date or modern numbers, there was a large survey by the ACHA looking at death among college students that was published in 2013, but was up through 2010. And we see a very similar pattern. Top cause, unintentional injuries. Second cause, suicide. Cancer is the third cause. And we see that homicide is a very low cause of death in college populations. And what I think is interesting about this is that, the proportions or the rate rankings haven't really changed that much over a long time. But if you actually dig into the rates of death from different causes, there have been lots of changes. And college is a very unique environment that has some really interesting features in terms of morbidity and mortality. Show the next one. So if we look specifically about suicide, for example, not sure if I can borrow your pointer there for a second. So this is a really well-known study of counseling centers in the Big Ten, so right where we are. And they've done a couple of studies. They did one that was from 1980 to 1990. And if you looked at suicide rates in the Big Ten, it's down here around 7.5 per 100,000. So, we think of Michigan as about 50,000. So, you'd anticipate maybe 3 or 4 deaths by suicide per year during this period. If you look at more up-to-date numbers, so they repeated this study or kept it going from 2009 to 2018. In the Big Ten, we had a small decline in in completed suicides, down to a rate of about 5.6 per 100,000. And like as everyone in this room will know, there are wide disparities in both gender, sex, race, and ethnicity in terms of how these impact multiple groups of our students. But what I find most interesting about this is that suicide rates for our students are much lower than age-matched peers that are not in college. And I think that's a really important part of the message, is that really being in college is protective. And it's not just protective for suicide risk, it's protective in all of the categories except for cancer. So rates of homicide are much, much lower in college students, and rates of unintentional injuries, including automobile accidents and overdoses, are also much lower in college students. So I think, in some ways this can be a somewhat depressing topic and talk, but I think one message is that really college is probably the safest place for a lot of our students to be, and that while there are still really serious adverse events that happen, the actual rate of those is much lower in college settings than in non-college settings. So that's kind of like the intro to suicide risk in college. And turn it over to Jim, I think.
Thanks, Chris. As Chris mentioned earlier, the campus environment has a lot of unique features. And I think, if I'm recalling correctly, most everybody who's attending here is on a college or university campus. So you're probably already familiar with some of this, but we thought it was important to talk about some of the unique features of the campus environment and some of the resources we have here to meet some of those unique and competing demands. So I was up at 3:21 this morning, adding some things to slides. So I'm really happy that we're able to see the slides right here on this little monitor in front of us, because I'm not exactly sure what's going to come up on the next few slides. Okay, so might be some surprises for me, I don't know. So one of the things that we wanted to try and do, we started working on this presentation, and a couple of the original slides were really terrific, but they were an attempt to kind of get at all the different and unique features of a college campus, and then all the different resources. And they were super complex. I mean, we were looking at the resources and we're like, dang, we do a really good job of trying to support students here, but it can be really confusing. And so my goal here is to try and make this as simple as possible. So you're going to see some kind of buckets of things, right? And we know that there are things outside of the buckets, and there's more things that are going on for students. But essentially, when we think about the environment here, we know that primarily because it is an academic environment, there are a lot of unique features to being in an academic environment that many of our students have not faced before, right? Kind of the unique rhythm of the semester, the kinds of ups and downs. So for newer students, that's something they need to learn how to negotiate. For more experienced students, while they may know how to negotiate those rhythms, there's still a lot of competing demands, which can create a lot of imbalance in people's lives, right? That's just part of being in an academic environment. We also know there are a lot of social complexity in this environment, and personal complexity in this environment. For me as a psychologist working in a university counseling center, one of the great things I get to work with students on is to figure out, who they are and how they want to be in the world. And that can be really confusing and complex, right? So that adds to the environment as students have new experiences or seek out new experiences or come to the counseling center to find out how they can find the courage to experience some of these new things on campus. So a lot of personal growth and development that goes on. So that makes the environment complex. I think the social environment is part of that growth too, right? Especially at a place like U of M, where students have the opportunity to be to work and live and study amongst such great diversity of all kinds. Meeting people from places that they've never knew existed or only thought about, or different walks of life. That adds to the complexity, but really the richness of this environment. But it can also be challenging for students as they kind of figure things out. I also wanted to note that there are work complexities. We have many students who are working while they are going to school, okay? That is difficult. That is challenging. And also, their students are making their first decisions about their career paths and where they want to go in life and what they want to do and what their majors are. So there's a lot of unique pressures in this environment. While as protective as it might be, it's super challenging, particularly because of the conflicting demands. And we know the things that are not in that diagram are things that happen around us, right? Things that happen on campus, things that happen in Ann Arbor, things that happen in Michigan, in the country, in the world. And that's been particularly challenging the last several years, right? As all these things are happening around us that many of us are finding challenging and maybe a little bit of lack of control, right? And so while this is a very protective environment, as Chris noted, it's also a very challenging environment for students. Thank you. So let's talk about some of the resources that we provide to help students meet those challenges and to support them. And again, I'm trying to simplify this into some buckets here. Student life is one of the mainstays for students on campus in supporting their personal and academic success, and we really focus a lot on their health and well-being. Resources in student life run the gamut from health services to the counseling center, to student legal services, to career services, to food pantry. And we recognize housing and dining. I need to mention our huge partners there too, right? We recognize that there's a lot we need to do to make sure that students have some of their basic needs and they're able to feel that support here at campus and have some fun along the way too. Of course, we have a lot of academic support that's focused on their educational experience. Our marvelous partners in academics, like our advisors, our faculty, our instructors. They help students, kind of shape what their academic career is going to look like here at the university. And then, of course, university-wide, there are, just some kind of resources that support being here, right? Financial aid, Office of General Counsel, those things that all students kind of access. We have so many resources here. Like I said, we did this really great bubble slide, and there were so many bubbles, they were spilling off the page. There's some trees on this slide because really, to me, it feels like this very rich ecosystem of support for students. But sometimes it can be a huge forest, right? And sometimes students can get a little lost in that forest. Sometimes they can't see the forest for the trees. More often than not, they see a tree, but not the entire forest. We really operate from there is a no wrong door for students, right? So with all these resources, it doesn't matter if, a student identifies in particular what they need or where they need to go. We have these tremendous collaborations and partnerships and programs, from on the academic side, student life, from the university, that we know that whatever door a student walks through, they're going to get connected with the resources that they need. So if a student goes to the Student Success Center in the College of Engineering because they're struggling academically, the advisors there might recognize, hey, there might be a psychological or health component to what's going on for that student. They're going to make sure that they refer them to CAPS or to health services to cite and address those concerns. So even though it's a very complex environment, even though there are a lot of resources out there, we count on each other to get students to where they are, where they need to be. Okay, this is the one I was fixing at 3:21 this morning, so let's see if I remember what I was doing. I think I was aware, I'm not sure. So we also know that even though this can be a very healthy and protective environment for students, it's a challenging environment for students, that they can take advantage of many resources. We also know that there's a lot of urgent care that sometimes students need. So we are very prepared to respond to urgent needs and critical incidents here at the university. So along the lines of prevention and mitigation, we offer same-day walk-in services and after-hours services for students who are experiencing an urgent need or critical need in their life. One of our great partners is the Dean of Students Office, which students can make use of when they are having, academic issues, when they're having housing issues, when they don't have enough food to eat, they might go to the Dean of Students office. And again, we know that if the Dean of Students office recognizes that there's a health or a mental health component to what the student is bringing in, they're going to connect them to counseling and psychological services or university health services. And we all provide same-day walk-in and after-hours services for students experiencing urgent needs, as do our great partners in the psychiatric emergency services as well, for students who might be struggling just that little bit more. We also are prepared to respond to critical incidents and events that happen in students' life at a higher kind of level. We have our clinical care management team, which is comprised of folks so it's, we've got this new unit, University Health and Counseling. So it's really, we're still trying to figure out how to talk about things. But that's comprised of care managers from CAPS and social workers at the University Health Services, and they work with students primarily who are trying to re-enter the university after a hospitalization. We also have something called the Dean's Behavioral Intervention Team. There's 3 of us on this panel who sit on this team. It's from the Dean of Students office, and it's a place where we recognize that sometimes students need a little higher level of care or attention, either based on the events that are going on in their lives or sometimes their behavior here on campus. But it's a terrific cross-functional team representing the entire university, really. And then for very serious matters, we also are prepared with something called the Health Advisory Team. Sometimes students being in college might not be the best place for them to be while they are trying to recover or recoup from a serious illness or some sort of event in their life. So, long story short, complex environment. Recognizing that there are a lot of resources and sometimes students need a little more, and we're prepared to provide those. So where does this adverse event review sit amongst all of this? And really what we are focusing on with this kind of new endeavor are folks that touch the University Health and Counseling Service in some way. And we know within the University Health and Counseling that we are all engaged in trying to manage the risk. There's a lot of challenges in providing services to students, particularly mental health and medical services. We also know that we're also always striving to improve quality and address safety concerns as we're managing risk, as we're providing the services. And so we have this serious event review committee now to kind of take a look at places where we might want to learn, things that have occurred that'll provide us an opportunity to learn and make some positive changes. And so, Angela, I think now it's your turn.
So I think we're talking about all of these resources across the university. The point that we're trying to make here is that our committee is new and not in response to a lack of resources. I think that we would all agree that the University of Michigan has very robust resources, and we're in a unique position that we've been granted the ability to think about preventive activities and to utilize some of our resources to think in new ways about how we can respond to these serious adverse events and potentially prevent them. So I'm going to speak now a little bit about healthcare quality improvement, which is sort of another discipline that may feel like a lot, but we kind of wanted to place our serious adverse event review in the context of all these different factors that are being considered. So healthcare quality improvement is a discipline that has existed for over a century. I would say our forefathers are thinking about things like the aviation industry, nuclear power plants, the car manufacturing industry, where there's a very low tolerance for serious adverse events, and we work in very complex systems. So these are just a few of these kind of buzzwords that you'll hear about in healthcare quality improvement. So PDSA cycles, or Plan, Do, Study, Act, on the left side there is one particular framework for an approach to improvement that we use a lot in medicine. And so this can be used both in hospital settings, in outpatient settings, in all different environments for all different types of problems. What we're talking about, serious adverse events that have occurred, you can't really do this PDSA stuff, but we just pointed out that these are some of the tools that are a part of the toolkit in a healthcare quality improvement approach. On the right side there, you'll see this Swiss cheese model that I think a lot of us have heard about, and when you Google this, you'll see all of these comparisons of the COVID-19 pandemic in different areas. But so the idea is that we think of the chance of an adverse event happening is decreased by us having these multiple layers in a system to protect from an adverse event. But each of those layers has different holes in it. So imagine these are Swiss cheese slices that have the holes in different locations, and you can't always predict where the holes may occur. And like Lindsay was talking about, we think of human factors, we think of technology factors, we think of all these different pieces of the puzzle of how these events occur. I think it's much easier to conceptualize quality improvement in an inpatient hospital setting because you can see the very direct outcome, like a surgeon performed a surgery to amputate a leg and they amputated the wrong leg. Like, wow, that seems like we could definitely do something different to prevent that from occurring. But when you look at an outpatient situation of this person goes to see their clinician every few months and something happens in one of those in-between times, it's not always a direct understanding of what happened here and was there an error on the healthcare side? Was this the natural history of this person's particular disease process? Was this other things occurring in this person's life? So these are just models to help us think about that. For serious adverse events, a root cause analysis is kind of a traditional language for thinking about events like this. So you can see on that left side, there's all these different steps that are recommended to consider in the analysis of a serious event that has occurred. And so there are different frameworks in different healthcare quality improvement sort of frameworks themselves. And I just show this as an example, and we're gonna actually show our framework for doing serious adverse event review. But I really like this fishbone diagram on the right side too. Sorry to add more jargon to you, but I think it's nice to show that on the right side there at the fish's head, this is when an adverse event occurs. And if we look back at the body of the fish and you look at those little sides of patient characteristics, individual institutional context, different factors, work environment, individual staff, organization and management factors, team factors, there are tools like this to help us to think about the big picture of why something has happened. I just wanted to give a plug here if this is tantalizing to you. You can investigate through the Institute for Healthcare Improvement various free, very comprehensive resources for healthcare quality improvement. I would just point out two here, the really nice white paper on this framework for safe, reliable, and effective care from 2017. And then this open school that are free courses that people can take in different disciplines in healthcare improvement. But there's this basic certificate in quality and safety, that's these 13 courses that provides a really nice introduction to this information. So I'm thinking about if someone's sitting here from another institution thinking about, gosh, should I consider something like this in my environment? You may have clinicians that are already trained in some of these healthcare improvement processes and frameworks, or you may consider having somebody do training like this. So now we're going to hone in on this serious adverse event review committee. So first is that when we're completing a serious adverse event review, we really want to have a focus on the system and not looking at who made the error, what happened that was wrong. This is not saying there was an error. This is not saying that something was done wrong. We're not using this to assign blame or responsibility to a particular party of something in particular falling through the cracks. We're recognizing that it's a complex system that we work and live in. And so when a poor outcome occurs, it is probably a multitude of factors and not just any one. On that note, practically, when we're doing our reviews, we would remove the names of the different clinicians and staff involved in the case because we're acknowledging that we're all human, we're all doing what we think was in our best judgment, and we don't want this to be an opportunity for the review committee to have some bias towards that person or towards that discipline. And then I also want to point out there is a different whole world of this discipline of peer review. And so serious adverse event review is not a form of peer review. And in fact, our recommendation from our lawyers has been to refer any of these serious adverse events for peer review separately from our event review in our committee. For a thorough and excellent serious adverse event review, different sources would say that we should do this in a timely manner, both because of better memory of the event, as well as just human factors that make us all more likely to want to take action in the face of something happening. So really, the ideal, if you were to be creating a committee like this and responding to a serious adverse event, would be to quickly learn about the event, decide if it should be reviewed, which we're going to go through, and then complete a review, which we're going to go through the steps of that, and then create final recommendations and determine who you're going to send those to or who you're going to share that with, which we're going to discuss all of this. We're not going to get into every detail of exactly how we do things, I think because it's hard without having a specific case and we don't need to speak of every detail. But I think the question of where does this committee lie within an institution like ours is a good one. And so in our committee, we mimicked this after the University of Michigan Department of Psychiatry Adverse Event Committee. And in both cases, they have been a subcommittee of the Quality Improvement Committee of the clinical department. And the reason for this is because of legal protections that Kelly's going to speak of. But just to point out that this is a subcommittee that lies under that Quality Improvement Committee, and that this is a separate group of people, and we only have ad hoc meetings depending on the different adverse events that occur. Thinking about who you might want to be on a committee such as this, this is the makeup of our committee. On the left side there is mostly individuals that work at our University Health Service, so our clinical arm. So somebody who has some expertise in quality improvement, a medical director, primary care physician groups, specialty groups, psychiatry representatives, nursing, social work. Those are the major groups in our clinic. And then on the right side there, you'll see other individuals. So at the University of Michigan, we're lucky to have a huge legal department. We're lucky to have a huge risk management department. We are lucky to have a psychiatric emergency room. We're lucky to have a robust counseling and psychological services. And so again, kind of thinking how you might use this as a blueprint for your institutions. That might be different in different institutions, but this is what we are blessed to have here.
Thanks, Angela. So I am the lawyer on the committee. I sit on the committee. And so part of my job is, especially because this is a new committee, we've established this year, this is new for the university, and we're kind of figuring things out as we go, because we're a little different than some of the quality review committees that might sit in a more traditional inpatient or hospital setting. But up here on your screen is a copy of the most relevant law when it comes, I would say, when it comes to forming these committees and having these committees function as well as they can. So this is pulled from Michigan Public Health Code. And this, you don't have to read it. Like many laws, it's boring and has too many words. But it basically says not only can you, University Health and Counseling Services, have a quality professional review committee, but we're going to give it an elevated, a boosted level of legal protection. We're going to not only apply any potential HIPAA confidentiality, but we're going to give it extra confidentiality because we know and we respect that in order for these committees to do their good work, they need to be able to function candidly and not think, gosh, what if what we're doing ends up with unintended audiences, because we're reviewing bad outcomes. And there at the university, many of our adverse events are death by suicide. So we're sort of uniquely situated in some ways because we're dealing with the context of grieving parents, grieving partners, and parents or partners who are coming to the university and saying, tell me everything that happened. I want to know everything that I can. It is a very standard request, unrelated to how a student died, for parents to come to the university and say, I'd like to have a copy of their entire inbox. And we actually often do provide that. So that is the context that makes us a little bit different, and why, as a lawyer, I really appreciate the added protection that the law gives any of the records or recommendations that this committee makes when we're reviewing adverse events. So that's the law. It exists. It's good for these committees to function so that we can thoroughly, candidly talk about what happened, why it happened, without sort of the risk of that information being used for different purposes. And if we hop to the next slide, these are some of the legal issues that we've talked about over this year as we've formed this committee. And the first one is the big one. So how do we maintain confidentiality of the records, the meeting notes, the report, the recommendations that we all might conclude when we finish an adverse event review committee? And so there's three things that the law gives us that wouldn't give other types of records that a committee at the university might create. So the law says that any of the records we create in the scope of this committee aren't going to be subject to subpoenas. They're not going to be subject to lawsuits, and we're not going to be subject to FOIA. So the University of Michigan is a public entity, so my inbox, for example, can be FOIA'd. Many people don't know that until their inbox is FOIA'd, but, and I get to read some of those emails, and man, wow, okay. So the lawsuits, we may have a med malpractice lawsuit, or we may have a negligence lawsuit where a grieving family is saying, I'm going to do everything I can to address what happened, and that may include blaming the university for a bad outcome, or an outcome that they certainly did not think or hope was going to happen. And our families have all sorts of levels of involvement with their students. And so they may say, okay, I'm suing the U of M, and I'm going to do discovery requests. You may have heard that term. It means they get to ask us for all sorts of information relating to the matter at hand, and usually we have to give them all of that information. But this law would say, even if their student's case was reviewed by this committee, those records are protected from that discovery, even if we're subpoenaed. And so again, it's that added sort of boosted layer of protection in addition to HIPAA that allows these committees to function. Another thing that we thought about was the scope of the committee and the scope of cases. So on any college campus, we have student deaths throughout the year, and not, of course, all are deaths by suicide or considered an adverse event. And so one of the questions we've sort of grappled with was, should this committee review cases where the student in question had little to no touch points with university health and counseling services? And I think we're still thinking that through, but one of the things that's my job is to think about, how do we maintain that confidentiality that the law gives us? And if we make our committee too big and include all the adverse outcomes on campus in the scope, are we losing the protection of that law? And so those are things that we've just had to think through, because the law applies to health facilities and agencies. It doesn't apply, for example, to the Dean of Students office. And then recommendations. So ultimately, when a committee review concludes and we say we should do this or consider this, or as Angela mentioned, let's send this out for peer review. We can basically, the general rule of thumb is you can share information with anyone who needs to know it. So there may be a report that's created by the committee that really doesn't need to be shared beyond committee members. But there may be recommendations that we can pluck out of that report and hand it off to the individuals who are relevant to those specific recommendations. And all of those things are meant to demonstrate, should we need to defend a decision as to why this information is protected and confidential, it says, well, we didn't give up confidentiality. We didn't just share this with anyone and everyone. We really did try to make it confidential, and that helps us if we ever have to defend that in a court of law. So that's the legal sort of framing that we've been thinking about as this committee has come to life. And I think it goes to Angela now.
Yeah, and Kelly's really pointing out, I don't know if we said it at the beginning, this is a new committee for the university that just started in August of this year. And so we're still figuring out some of these details, and we're going to talk about that too. But next, I kind of wanted to show you a framework for how we have set up our committee to conduct adverse event case reviews. So we have just this listing of how we would go about gathering all the information and creating this so-called report. So we would gather all the information about the case from reviewing clinical documentation, considering different sources, conduct interviews with our clinicians. We also think it's a very important part of this to include clinician support in review of these serious cases, and then to come up with this identification of different deficiencies or areas for improvement and a recommended action plan. So we're going to go through one sort of example case that is not based off of any true case, and we're going to show some other example cases for consideration in these next set of slides. Again, I just want to point out this is a serious matter and may be unsettling, certainly for everybody to think about that, and you're welcome to walk out if you need to.
Yes, thank you, Angela. So again, take care of yourself however you need to during this part of the presentation. I'm going to do my best to give you all an example of a case that we would review on this committee and the specific steps of that review process. Again, this is just an example that was created for the purpose of this presentation and does not represent any real case. So there was a student suicide completion near campus during the current semester. This student was involved in receiving care from University Health and Counseling during this term, so recently, and they were also engaged with multiple campus resources. So hypothetically, they may have been engaged with fraternity and sorority life, maybe a club sport, maybe more formal resources like receiving services and support from services for students with disabilities or academic advising. So we would review this case for this committee because it meets the criteria. It is a serious adverse event. It is a recent and current UHC patient, so it does meet the requirements within the scope of this committee. So one of the things that is done first is a review of documentation to figure out exactly what happened leading up to this case. So one of the members of the committee would be appointed as the main investigator, and they would go through this process to review the documentation, specifically reviewing clinical social work documentation. Maybe the student was seeing a primary care physician. Maybe they were getting therapy here on campus. Perhaps there were referrals made to other resources. So when this documentation is being reviewed, we're sort of asking questions of the documentation itself. So in the last therapy appointment, was a safety assessment done? What were the outcomes of that safety assessment? Did we explore risk for suicide? Were necessary resources provided? So were they connected with outside resources for more intensive therapy? Were all of their basic needs met for life stressors like food insecurity or housing? Were the appropriate referrals made? Was follow-up on those referrals conducted? Was there anything missed? So we try to do a pretty robust job of following up with patients who may have no-showed to a scheduled appointment or kind of went dark. And we honor the opportunity for patients to step away from their healthcare, but we do try to gently poke them and make sure that they know that we do care, and if they want to reconnect, the door is open for that. So Those are the types of things that we're looking for. And then outside of just the documentation piece, the clinical documentation piece, we're also looking at the review of the care system as a whole. So as Jim was talking about, these other teams on campus, like the Dean's Behavioral Intervention Team, Clinical Care Management Team, these are groups of people who may be supporting individuals. Additionally, in this case, if the student was involved in fraternity and sorority life, they're going to have some formal supports in place from that institution as well. So looking into, was the student reviewed at any of these team meetings that are attended by campus partners and interdisciplinary teams? Were they being formally supported, let's say, by the Office for Conflict Resolution or students, services for students with disabilities? What were the formal supports in place? Who knew this student, and who were the people involved in supporting them? And then we conduct clinician interviews. So prior to the interviews taking place, it's recommended that there's a formal process and a standardized process to inform involved clinicians that a student or a patient has died. So important note that ideally clinicians will be informed of that news from their supervisor or the appropriate person prior to somebody from the Adverse Event Review Committee speaking to them. And then you can, I think it's big enough, see kind of what that initial conversation from the reviewer would start with, sort of just acknowledging that we are sad to hear about the death of this student, and also explaining the purpose of our committee is really just to gain more information and not to punish or find fault. One of the key parts of that is making sure that that clinician has the supports that they need. So the question would be asked, you know, do you have what you need? Do you know what you need as far as learning of the death of one of your patients or somebody that you were involved with? And do you have any suggestions on support systems that might be helpful to you during this time? And then making sure that they are also aware of available supports to them that are in place. Resource finding is such a big piece of this work for both students who are in distress and faculty and staff who may have experienced something like this as a provider. So making folks aware of faculty and staff counseling and consultation office. Essentially, it's therapy opportunities for faculty and staff here at UMich. Potentially an opportunity to debrief the experience with this patient with other clinicians who were involved, to sort of get that support from your colleagues. So making sure that the clinician has the support they need throughout this interview process. And then, you know, by reviewing the documentation, by finding out who was involved with this student who died, we're looking for deficiencies or areas for improvement. So we're going to be asking the question, was the standard of care met? And even if the standard of care was met, it doesn't mean that there's not room for learning or opportunities for improvement. So things that we might look for as far as deficiencies would be where there are missed opportunities for communication, where there are opportunities for teams of folks who are very interconnected to become involved to support this student. Was confidentiality a false barrier? So sometimes I think we get very nervous about breaking confidentiality, and we have to follow many different acts and laws, so FERPA and HIPAA and the Michigan Mental Health Code. And a lot of the time we think to ourselves, okay, I can't say anything because this is protected information. And are there sometimes appropriate times to break that confidentiality if there is imminent risk, or find ways to gather resources without breaking that confidentiality? And then, were the appropriate resources deployed? Did the student have a basic understanding of what resources were available to them? Did anybody talk to them about ways they might be able to seek help when they were struggling? And so, if there were deficiencies in those areas or identified areas for improvement, the team would want to create a recommended action plan to specifically target interventions that can take place to improve care in the future. So some examples of these would be, for communication, making sure that campus faculty and staff are aware of resources. So Jim mentioned, a professor or an academic advisor might say, gosh, this person is presenting to my class and they mentioned something the other day about self-harm, or they're presenting really disheveled and appearing in a way that's really concerning to me. Does that professor know who to go to next? Again, no wrong door is sort of our approach. So hopefully they're going to go to any of the systems on campus who can then direct the student and the supporting staff to the next level of care. Ensuring that the collaborative meetings that do exist on campus have the right people at the table. So in the event of a student being presented at, for example, the Dean's Behavioral Intervention Team, which me and Jim and Kelly all sit on, Kelly may bring a case to the conversation and I learn, oh, that person is supported by one of the psychiatrists at University Health Services. Now I know that this person is presenting in this really concerning way, and I can let the psychiatrist know this additional piece of information. Again, considering FERPA and routes of communication that are legal. And then on that note, figuring out where and how to communicate concerns for students without breaking confidentiality. So we might say, if I had a student, use hypotheticals, if I had a student who had this specific concern, where would I go? And if I find out where to go, offering that student a warm handoff. So saying, hey, there's a really great resource on campus that I am certain can help you better than I can. Again, just sort of like a hypothetical walking through a student through this. Would you like me to send them an email and copy you? Can I introduce you directly to them? So making sure that in times of extreme distress, students have some help, and that identifying those barriers to utilizing the resources and kind of figuring out ways around those barriers. So recognizing that it's really hard to get help when you're already down and already struggling, and expecting students to do that entirely on their own is something we want to be thoughtful about. And then that action plan would go to specific staff members by way of assignment, essentially. So you might get an assignment, hi, we learned about this resource. Can you please share this specific resource with your team so that your team knows to spread the word to their contacts?
Victor, are you up for running through these next few?
So we're going to go through a few other cases, not in so much depth, but only to kind of share that there are different aspects of different cases that speak to the scope of this adverse event committee and whether we would review them. So this case, I'll just read it really quick. Suicide attempt by a graduate student resulting in permanent physical disability, paraplegia, occurred out of state. And this would be a case, for example, if somebody was on spring break away from the university, the question would come up, and it has come up, what responsibility does the university have in cases like this? Maybe they're home for the summer. Recent international field work, they did have a history of depression, evaluation and treatment. However, it was 3 years ago and they had not followed up. So again, how far back do you go in terms of bearing responsibility for a case like this? So obviously it would meet the criteria for being a serious adverse event. There was permanent, significant physical injury as a result of the event, but we really haven't, been treating them. We haven't had touching base with them. Not only that, but they weren't even really close to campus at the time of the event. So the decision would be typically that it would not be within the scope of this committee.
Doing great.
Case 3, undergraduate student cyclist death after collision with a motorist in downtown Ann Arbor. Obviously, serious adverse event. Students brought to the hospital, resuscitation efforts were unsuccessful. Student was seen at the campus health center for a completely unrelated issue, primary care issue 9 months earlier. So while, yes, it is a serious adverse event, yes, we were technically treating them, but for an unrelated condition. But because, again, it's sort of outside the scope of any sort of intervention that we could make, unless we were going to make some kind of traffic intervention, there wasn't a proper stop sign or something. This typically would not be something that we would review within the committee. And I would sort of loop back to the intended purpose of the committee is to prevent future issues, and it's unclear whether we could prevent anything based on a review of this event. And last but not least, international undergrad student admitted to U of M hospital, unresponsive secondary to alcohol intoxication. After they were resuscitated, they admitted it was a suicide attempt, were later hospitalized on the psychiatric unit, and then referred to other treatments. After the hospitalization and treatment, they were referred to the University Health Service. So again, you have to ask these questions. So was there a serious adverse event? It kind of depends on how what level of event you consider. In our case, we're looking at death or serious significant permanent injury. In this case, that wouldn't apply. There may be different levels of adverse events that you would review at your colleges or universities. They were, again, not a current patient, so we wouldn't have had a chance to intervene. So if there were screening tools developed and there were no red flags, and we hadn't really touched base with the student ever in terms of campus resources, there wouldn't have been any way to prevent this event, so we would not typically review this type of event.
I just wanted to mention a few of the ongoing challenges for this group. I know a number of us have mentioned that it's new, which is exciting, offers exciting opportunities to, I think, do good work and try to be responsive when bad things happen and really dig in and see, like, is there something we could have done in this situation? Are there system failures that we could fix to prevent this from happening in the future? But because it's new, it's also, it's hard. I know Victor just mentioned about the scope, what is your sort of bubble of responsibility or maybe bubble of areas that you can impact? And we've struggled with that a little bit, and I think we probably will continue to, and that's probably a good thing, being thoughtful about how we want to interact with things that are on the margins where we may or may not have direct ability to impact future outcomes. I think the other areas that we're working on, but we have not figured out exactly how to do it, is how to make meaningful recommendations that are both specific enough that they can be implemented, but are also meaningful and get to the right decision makers to actually make those changes. I mean, there's no, we have no interest in coming up with a vague list of recommendations that, just go into a file cabinet. Like, none of us would spend our time doing that. And so we really want to make sure that we're focusing on specific recommendations that are doable and that are, trackable, so that we can see how they go and hold people accountable for doing changes that they say they can do. And obviously, the campus is huge, and so there's tons and tons of resources. And one of the things that I think we're going to continue to see is just the kind of intrinsic difficulty in a very complex situation with very amorphous communication lines, and a lot of both staff and student throughput turnover. So much of this is information-based, and it's hard to keep everyone on the same page when the people keep changing. And obviously, change management is always a difficulty. How do you implement these things when you do figure out something that you need to fix? It's often not as simple as just saying, we need to do this. That doesn't often have it done. Victor is a really experienced person on another adverse event review committee and has done this a lot. And we wanted to just see if he could talk a little bit about some of the outcomes from other types of settings. So some of the examples of things that might come from these kinds of committees that would be helpful on students. His expertise is really in a psychiatric emergency department, but there's a lot of crossover with campus settings.
Yeah, you're really overselling things, but we can learn things and we can make changes. I would go again back to the intended purpose of this review committee, which is to make systemic changes that can prevent future injury or death. And anyone who's done a very, very in-depth review will know that you kind of get to know the student, you kind of get to know their families in some cases. And I do think, this may sound grandiose, but I do think that there is an honoring of the student or the individual in terms of making changes to prevent future issues. So just a few case examples. So there have been cases in which we've learned that we need to change our screening tools or the widespread screening programs that we have. Even 10 years ago, 15 years ago, which is not that long ago, we really did not screen, for example, for depression or suicide in primary care departments. And we've implemented changes. So we can do this. We've picked up more cases that maybe we would have missed before. In many cases, we've changed our suicide risk assessment and also intervention protocols. So for example, it's increasingly become the standard of care that you have a comprehensive suicide risk assessment when you go into the psychiatric emergency department, safety planning on every case that is high risk. These are things that, again, did not exist a few years ago, and we're trying to implement tools so that it happens every single time. I'll give you one example. So in our Department of Psychiatry here, if you go back 10 years, we did an audit of how many notes had any sort of mention of suicide risk or an assessment of suicide risk, and the percentage is very low. So we went through this whole process of creating templates so that in every single clinician note at every single visit, there was some mention of that. So it sort of prompted clinicians to ask, and then they have to document what they've asked. In terms of communication tools, we know that many, if not most, adverse events, if there is a systemic change as needed, it has to do with lack of communication or poor communication. There are so many examples of this, and there's always some kind of something gets missed in terms of communication or inadequate communication. And so we've talked a lot about how do you hand off cases properly so that the next clinician knows exactly what the safety risks are. Leveraging technology, obviously technology is a double-edged sword. We we all know the evils of technology, but there are some benefits. And there are ways through electronic medical record changes so that we can kind of catch people more, do a little bit more accurate assessments. And then built environment means reduction. There are a lot of examples of this, and kind of it goes back to cases in which we sometimes decide if there's a systemic change that is needed, that this is a situation that should never happen again, these never again situations. And there are examples of that. I'll give you one case that went through our department about 10 years ago, where there was a decision made not to admit to the hospital, and one of the potential factors in the decision was financial, that we did not have insurance authorization, or we weren't guaranteed payment for that patient's admission. And we decided after a very in-depth review that that was never going to happen again. We would not make a decision, a clinical decision based on money. And so we implemented protocols so that if there was a question about money, we would admit, and the hospital would essentially eat the cost for that. So changes can be made, to basically say we should never let that happen again. If you go to a parking structure here near campus or in Ann Arbor, you will likely see that there's fencing at the top of those parking structures. Why? Well, a relatively common method of suicide here in this city has been jumping from high parking structures. The decision was made to kind of do this means reduction to reduce the risk of suicides in that method. I'll give you one more example, a more widespread example. You may be aware that the Golden Gate Bridge just recently implemented very large barriers, because the Golden Gate Bridge is the site at which more people die by suicide than any other site in this country. So after decades of advocacy, they've overcome the two major impediments, which were financial, as well as, believe it or not, there was an argument that it sort of detracted from the aesthetics of the Golden Gate Bridge. But regardless, the decision was made that they would put up barriers so that if people jumped, they would sort of not fall into the water, but would instead fall into some kind of netting to catch them so people could intervene. So there are some really, actually very real outcomes and interventions that can be made based on these events that can actually mitigate future problems.
Great, thank you. I'm going to give us back to technology here and put up the QR code again. These are questions that have been asked so far. So you have the opportunity to ask a new question or to thumbs up a question, and that will bring it to the top here. So I think some of these are a little bit out of scope. So how are students informed about different services available to them? About what percentage utilize these services? I think that's an excellent question. I'm not sure anybody on this panel is in the best position to ask it. I'm going to move on to the next one. So curious how your review of recommendations may differ for our online program students at U of M. I think thinking about the scope of this particular committee in being able to review cases of serious adverse events that occur for students who are currently engaged with university health and counseling is a major question there, that I think there is the opportunity for students that are completing online programs to be patients at university health and counseling, but I'm not certain that that happens very often. I know we have with our Flint and Dearborn campuses some pilot programs to increase access to the university health and counseling services, and the different Dearborn and Flint campuses have their own counseling and psychological services. So I'm not sure. I think that's one of those questions as we're determining scope and as different events come up that we would have to determine if this is appropriate for our committee to review.
One thing that may be relevant to that, Angela, is so U of M doesn't have a ton of purely online programs, but I believe students enrolled in those programs, so School of Information is one of the big ones that has purely online programs. I don't know that those students actually are charged a UHS, a University Health and now Counseling Services fee. So I don't know if they get to take advantage of some of those types of resources on campus. But one of the things that I know we've done across campus that came out during the pandemic was sort of better intaking students who were seeing clinicians remotely to ask important questions right at the get-go. Jim and I worked on this together to say if something doesn't go well during this call or after, do we know where this student is geographically, physically? Do we know how to get a hold of them? Do we have a callback number? And so those were some of the new protocols that were implemented to better support our remote students, whether they were online students or just choosing to use services remotely. And so it seems like that's become the standard now. That really was sharpened during COVID when we had so many students utilizing resources remotely, not out of choice at the time.
And then, Angela, if you can go back to that first question, I think I can take a stab at answering at least part of it.
I didn't know.
How are students made aware of resources available to them, I think. One thing that the university did this year was initiate a mental health mandatory class for all incoming first year and transfer students. And so it was required to become educated about mental health services at the university for that cohort. And there was a pre-test that was asked of those folks taking these modules. And one of the questions that was asked was phrased that the university has a lot of resources to support you, including University Health Service and CAPS. Here is information about those two services. And then the question posed was, do you think you can reach out to those services on your own, or would you like additional support reaching out to those services? And if folks answered, I actually need additional support, then a team of social workers reached out to those folks, offering ways to get them connected directly to care and kind of walking them through that process. More than half of the students answered that it did not apply to them. And then of the students who answered that they might need help, most of them found that they could seek that care on their own with the information provided in the module itself. So phone number and websites were included in that mandatory pretest.
So that we may have bitten off more than we can chew. We're impressed with the volume of questions. Excellent. Maybe we'll try to take a stab at a few of the easier ones. We can speak into the mic for stronger sound. We got that one. I think a few of these are really interesting. So what are the legal protections for clinicians when university is sued? University of Michigan is self-insured, and university defends our clinicians. And we also have a well-built-out risk system and a commitment that when there are errors that are made, we pay. Essentially, I think that's the short answer. Is that, you know, we don't, when we identify that we made a mistake and did something wrong that we should have done better at, we want to acknowledge that up front with people and not make not drag people through a long court process to get compensation.
There's a few questions here about would we involve in our recommendations and in our interviews and investigations non-clinical resources on the campus or potentially faculty involved in a case? And I think the short answer to that is yes, but it depends. And so we certainly have talked about the idea of the interviews could extend beyond just the clinical staff. And we could certainly interview different individuals, and we could consider, based on a review of the legal protections and those individuals' involvement, whether we would invite them to any portion of the committee meetings. I think this brings up another question that's commonly asked of like, do the involved clinicians actually sit on this committee and review the case with you? And I would say in the healthcare quality improvement literature and across different institutions, it's different. Some institutions have a very hard, no, this person should never be involved in this. There's too much risk for bias because of thinking about their personal involvement. Others would say yes, depending on the clinician and depending on how we involve them. Our so far discussion and the involvement in the cases we reviewed has been that we have the interviews, we invite them to participate in the committee, perhaps in coming to a meeting that's not going to be when we make our final recommendations or we make a final assessment, but that we would invite these type of individuals to talk with the committee if that was of interest to them, and particularly that may be a source of support for them.
Dr. Hong, there was a question for you here. Can you elaborate on specifics around updated screening and assessment protocols that might have come from committees like this?
Yeah, so basically, this is a rapidly changing issue in terms of standards of care. So an increasing standard of care is for clinical settings. So this is hospital and outpatient clinics, that every new patient gets screened for depression and suicide, certainly substance use as well. I think there's still maybe a question, and it may be an evolving thing as to whether you do that at every single visit, especially in non-mental health settings. So that's one thing that's definitely coming to the forefront. A few things that are not yet considered the standard of care, but I would predict that they will be. And this is mostly for more acute settings, although it could be implemented in ambulatory settings as well. And those are a few things regarding things that mitigate suicide risk, both in terms of attempts as well as completions. And one is, I mentioned before, safety planning. So it's anytime somebody is, moderate or high risk for suicide, you're going to want to do a comprehensive safety plan with them. What are your triggers? What are things you can do to self-soothe? Who would you reach out to? I mean, this is all like on a document. Who you'd reach out to in a time of crisis, both socially but also professionally. Make sure that there are suicide hotlines on there. And then how can you make your environment safer through means reduction? Another thing that is a little bit more recent, something that we have implemented at our hospital, but not every hospital has, which is some kind of follow-up contact, especially if somebody's been admitted to the hospital or there's just some kind of general concern about specifically about suicide. And so evidence shows that if you have some kind of contact within a few days to a week, it definitely reduces the number of suicides. I'm not going to go through all the evidence, but it's pretty robust. And so we have implemented a follow-up call system. So everyone who comes to our inpatient unit or psychiatric emergency service and there's some kind of elevated suicide risk, they get a call within 48 hours from a social worker, usually, or a doctor, basically saying, how are you doing? We're concerned about you. Have you been taking your medications? Did you make it to that mental health appointment? Do you need help of any kind? And I will say that I believe that we've saved lives doing that. We've caught people in another crisis, invited them back, and then admitted them to the hospital. So just a few things to answer that.
I have an easy one here. How is your committee notified of serious adverse events?
So, the good thing and bad thing is that thankfully deaths are fairly rare, right? It almost always comes to our attention. It often comes through one of the leaders, so our Dean of Students office, or through our Executive Director, Lindsay, or to me, I'm the Medical Director at UHS. Essentially, we hear about every death, and usually right away. They're so shocking, so traumatic for everyone involved. And there's obviously Jim and his team at the Counseling and Psychological Services is always involved right away. They always know right away because they provide so many supports to people around students who die. So that's the short answer. And then the longer answer is that then when it finally gets to either me or Dr. McGrady, we review those. We do like a little preliminary review of those cases to try to make a determination if it fits into the scope of this committee. And if we have questions, then we go to the bigger group.
I think there's a lot of questions, including this bottom one on the slides here regarding scope. If prevention is the goal, aren't you missing cases if you don't investigate them, if they're not seen at one of our clinics? There was also a question about, should you extend something like this to faculty and staff? And I think certainly all of us would agree, like, gosh, we would love for there to be a forum for that. We're utilizing this quality improvement legal protection framework of our scope of this particular committee is only to review the cases where we have been involved in the clinical care of those students and those faculty or staff or community members. Certainly there's the opportunity to refer these cases to other groups that could be involved. So thinking like, for example, a lot of the faculty and staff would likely be patients at Michigan Medicine, the University of Michigan's Academic Medical Center. And so they have similar committees like this. And so depending on where that person sought care, they might be reviewed under that. For cases where there is a student who completes suicide who was not engaged in any resources, absolutely that's a frustrating case for us. And I think thinking about Dr. Mortensen as our Chief Mental Health Officer, this is a new role. We're thinking about how to be more involved and how to make sure everybody has access to these resources, doesn't feel intimidated to seek them, and that we are able to meet everybody where they're at. There's no open doors everywhere. So I think we're doing what we think we can. I think we're here as a part of all of us having this question of what else can we do. But because of the legal protections of this particular committee, we're only able to review those cases that have been seen in our setting in the clinical manner.
I would also add that part of the gap that this committee fills it's not meant to be a campus-wide adverse event review committee. And that's in part because we have so many good resources that already exist in that space. So we have we're U of M, we have lots of money. We have lots of resources and people dedicated towards harm reduction and wellness for our students. So when bad things happen, regardless of whether it's a elevated to be an adverse event, we have people who are on it, teams dedicated towards harm reduction and wellness. So I think that was, this coexists with those already existing groups.
Maybe last question here, because it's kind of an easy one. It says, I understand the legal protection, but how did you make the case to the administration and or board, AKA probably non-lawyers, that you should do this? And I think that one's easy, mostly because we have a really supportive administrative structure here. We haven't spoken to anybody who has been less than 100% or 110% supportive on this. I think all of us know that these are devastating events, and the question is only like, what can we do? So we never had to do any convincing of anybody. And I think it speaks to sort of like the general approach towards trying to always be better and do better. Really fits in with the quality improvement framework in healthcare, and also just the general sort of intellectual environment of a college campus where people are trying to learn and try to make things better for everyone. So.
All right, you see some other common questions here. I do want to address this top one because it has 8 upvotes. Do you consider permanent psychological harm as a serious adverse event, such as might occur in a sexual assault? Again, this is one of those hard questions where I would say absolutely yes, I would consider that to be a serious adverse event. The challenge is in identifying that. And if that sort of case were to come forward to this committee, I think absolutely we would consider reviewing it. I think the challenge kind of in our current systems, though, is figuring out how do we identify those cases specifically. And a lot of that comes down to the issues that we've talked about here of confidentiality, of our documentation, of the terms that we're utilizing in our notes and in the ICD-10 codes, for example. For me as a physician, thinking about how would I identify those cases. I think on the other side, we can think about as a group, how do we ensure that our clinicians are educated and aware of the serious potential impact of something like sexual assault, and that that is a harm that may be lifelong, and how do you document that in a chart, and how do you approach that? I think in some environments we do that very well. I think we do it relatively well in this environment, and I've worked in other environments where I think that there's a lot we could do it a lot better.
Yeah, I think the only other thing I'd say is, sexual assault is a crime. And so I think there are other processes that typically play out in those scenarios that it's just like a little bit of a different bucket, I would say.
And then additionally, we do have a sexual assault response team. So an interdisciplinary team of folks who are designed to discuss sexual assault rates, things that we're seeing, and potential supports and interventions for that specific need.
I think I'll do one last question that it's fallen down here, but I liked it, of what are the suggestions for starting a committee like this for a smaller college campus? So I think my first stab would be I tried to lay out a framework there and different individuals who would be a part of the committee. I think that the challenge of having a formal clinical space may be an issue for certain campuses. And so certainly I think that could be an offline conversation if somebody wanted to start talking about it with us. I think a major benefit we have in this one, again, is those legal protections. And so I'm not sure what the resource load would be at a smaller university or a smaller college.
And I would say, so these committees can function without the protections of the law, just like all of our core campus resources exist. And so it's not a barrier, it's just a benefit if your college campus does happen to have a clinical setting. That is the sort of traditional home for a committee like this, but we have all sorts of committees and resources that exist under other non-healthcare settings that do this good work. So there's still room for it, even if it's a school or university that doesn't have a clinical setting to sort of latch on to.
We want to respect everybody's time, and it's 10:33. But thank you for all of these questions. I hope that this sparks more conversation and that we've learned something from each other.
Thank you.